Welcome, everybody, and thanks for joining. So I am Aimee Cambell, and I'm an assistant professor and research scientist in the Department of Psychiatry at Columbia University Medical Center and New York State Psychiatric Institute. And I've been in the greater New York node for many years now, since about 2003. We're going to be talking today about a CTN-0044, an internet-based intervention. I just wanted to give a shout out to a few of the people that are on the call today who participated in the trial itself, including Dean and Aaron and Gloria and Sharon and Joanne and others. So glad that you're joining us now. And I'll let Ned introduce himself.
Edward Nunes, a professor at Columbia University Medical Center and New York State Psychiatric Institute, a principal investigator on the New York node of the Clinical Trials Network, and I was the lead investigator on CTN-0044.
Okay. So this is just a list of the learning objectives we will be covering today. And before we get started, we just wanted to get a sense of the folks that are on the call and whether or not you've had any experience using a technology-based intervention or app for substance use disorder treatment or recovery. So when we started CTN-0044, it was 2009, 2010. Very few people had any experience at all with using technology-based interventions in community drug treatment programs. But of course, with the speed of technology development, that could very well have changed 6 years later. So we just have a brief poll. So if you want to go ahead and answer the question, and then we'll see who we've got on the call. All right, so let's go ahead and close the poll. Okay, so about a third of you have had some experience using a technology-based intervention. Perhaps some of you used this, had that experience in CTN-0044 and others
Right.
in other ways. To start off our presentation today, just to give kind of just a very brief overview of thinking about the promise of technology for behavioral health, including substance use disorder treatments. So we know obviously that mental health and substance use issues are common, yet we continue to only be able to provide services for about 10% of people who require them or meet criteria for substance use disorders. And there's also been an increase in service delivery demand, so especially through recent legislation, including mental health parity and the Affordable Care Act. Substance abuse treatment insurance has become more readily available, and so more people may have, or more people are wanting to access treatment for addiction issues. And so technology is one way or one critical component that can help us to promote access, perhaps do so in a cost-efficient way and with effective care. And we know that technology in general is ubiquitous. So the graph here on this slide shows that 64% of U.S. adults own a smartphone, and about 85% of U.S. adults have internet access in general. And that the gaps between internet access by racial ethnic categories, by rural and urban differentials, and by age are decreasing. So more and more people are getting access to internet and thus might be primed for internet-delivered interventions. So a few of the ways that we can think about using technology to address some of the traditional barriers to substance use disorder treatment. So technology enables the widespread reach of evidence-based practices. And so when we think about this, we're not restricted by time So technology is available 24/7, or potentially setting. So we don't have to go to a physical building potentially to access different resources and services. It can also extend care provided by clinicians and increase service capacity by potentially allowing programs to see more people. It can improve standardization and quality. So interventions that are delivered through technology are consistently delivered. This may reduce the cost of training and the cost of clinician time. Technology-based interventions can sometimes help reduce stigma and barriers that result in health disparities in accessing recovery services. And it can foster engagement to enable individuals and their support networks to lead in their own care management. So technology can empower people to really do some things on their own, to educate themselves on their own, and as we've seen in some of the studies that we've worked on, can bring some of that information back to their treatment programs in a very empowering way. And through the use of technology with things like electronic medical health records and other sort of dashboard type technologies, you can really enhance the collaboration, communication, coordination, and continuity of care among providers using real-time information. So these are all potential ways that technologies can help to address some of the long-standing barriers that we've seen in addiction treatment.
Okay, so I'm going to talk about the rationale and the design of the study, and then Aimee is going to take back over and present and I'm also going to cover the primary outcome analysis, and then Aimee is going to take back over and talk about some of the interesting secondary analyses that have been done subsequent to the primary outcome analysis. So CTN-0044 was commissioned by the Clinical Trials Network because technology-based interventions, computer-delivered interventions, were emerging onto the scene during the early 2000s and mid-2000s. And there were already some promising products out there. And the therapeutic education system developed by Warren Bickel and Lisa Marsh was one of those, and that was the intervention that was ultimately chosen to be studied by the CTN. What this is it is largely a didactic, educational kind of intervention. It is a combination of community reinforcement approach and contingency management. So contingency management is well known to everybody, and what the therapeutic education system does is it implements an easy-to-use contingency management system on the screen of the computer. So the clinicians or the research assistants enter whether or not the patient has produced the target behaviors, which in the case of this study were interacting with the computer modules. That was a target behavior. Abstinence from the primary drug of abuse, abstinence from secondary drugs. Those behaviors won tokens. The staff needed to enter that information into the computer, and then the computer kept track of how many prizes the individual was due to win, and so forth, according to the contingency management system. The community reinforcement approach is a cognitive behavioral counseling method that teaches patients both relapse prevention skills, similar to cognitive behavioral relapse prevention. It also tries to convey social and other kinds of skills that will be helpful to individuals in building a substance-free lifestyle after initially becoming abstinent. So both community reinforcement approach and contingency management had extensive empirical bases showing their efficacy and effectiveness. At the time the study, our CTN study, was commissioned, therapeutic education system, which is the computer-delivered version of this, had been tested in one small clinical trial by Bickel and Marsh. The citation is there, 2008. And they had shown that TES was increased abstinence rates in a group of opioid-dependent patients who were being treated with buprenorphine. It increased abstinence rates over counseling alone in combination with buprenorphine, and it was of equivalent efficacy to community reinforcement approach plus contingency management, delivered 3 times a week by a human therapist. So perhaps somewhat disconcertingly, it seemed to show that the human therapist could be replaced by this computer. That theme is a bit of a sticking point and a concern with this type of intervention, and we can come back to that in the question and answer period. And there have also been some subsequent studies, including one where TES, which is the TES without the contingency management, was superior to counseling alone. That was a study conducted in methadone maintenance clinics. We raised that because one of the things that we had to decide in the design was whether we would study TES as a package, that is the combination of contingency management and community reinforcement approach, or whether we would disentangle those components. So there are those who would maintain that the effect of TES is largely due to the contingency management. Does the addition of a CRA really matter? To answer that question, we would have need to have a trial of at least 3 arms: treatment as usual versus contingency management plus treatment as usual versus treatment as usual plus the TES package, contingency management plus CRA delivered by the computer. And with NIDA, we ended up deciding that this type of design was too complicated. We just wanted to test the package. And there was, as we said, previous evidence from the literature on contingency management and CRA, as well as from the subsequent literature on TES, that the combination is greater than the sum of its parts, that this had already been shown. And again, in CTN, this was an effectiveness trial. So the purpose of this was to test the combination package in community-based treatment programs as it would be used in the community where the rubber meets the road. So this is the study design. Briefly, patients were screened. This was an effectiveness trial, so there was an effort to keep eligibility criteria, exclusion criteria to a minimum. We wanted a maximally representative sample. Patients obviously had to show up and go through a research screening, which is always a bit of a hoop to jump through. Once patients went through that and were determined to be eligible, they were randomly assigned either to treatment as usual or to therapeutic education system plus treatment as usual. And 507 were randomized. It was a 12-week trial, and then that was 12 weeks. And then there were follow-ups 3 and 6 months after completing the trial, which you can also think about as being 6 and 12 months after patients were randomized. So a fairly straightforward 2-arm comparative effectiveness trial looking at standard treatment versus standard treatment with the addition of the computer-delivered therapy, TES. So, details of the TES. There are 32 core and 30 optional modules. Each of these modules takes 10 or 15 minutes, maybe 20 minutes. The patient sits in front of the computer and interacts with the computer. The computer delivers text content. It delivers the content through audio, so you don't really have to know how to read very well to interact with this thing. And it has little vignettes filmed to illustrate key skills like drug refusal skills, how to say no when somebody asks you to take drugs, that sort of thing. It uses a fluency-based instructional and experiential learning thing, which basically means that it asks the patient questions throughout each module. Depending on whether the patient's asking correctly or not, it may slow down the presentation, it may repeat parts of the presentation, and so forth. There was a prize-based contingency management system, intermittent schedule of reinforcement, which means that if the patient earned a token, sometimes that token just said good job, and sometimes that token translated into winning a prize. This was Nancy Petrie's prize-based contingency management, which was intended to create a contingency management routine that would be relatively inexpensive and able to be implemented in community-based care. And in fact, patients in the TES condition ended up earning on average about $300 worth of stuff.
A little less.
A little less, 270, something like that, yeah. So, you know, it was money, but not an overwhelming amount of money. If in fact that is creating better outcome for the patients, you can make the argument that it's worth it. So here is a list of the core modules. We won't go through them all, but what's a functional analysis, self-management planning, introduction to problem solving, drug refusal skills, coping with thoughts about using and craving, managing negative thinking, managing negative moods and depression, a lot of good cognitive behavioral stuff. And there's also this relationship type stuff, attentive listening, giving and receiving compliments. Somewhere in here is how to have a disagreement with your significant other without having a fight, things like that. Good, useful stuff. And there's also HIV risk reduction education. So, again, it was a two-arm trial, treatment as usual versus treatment as usual with the addition of the computer-delivered TES intervention. Primary outcomes, there were two primary outcomes. Abstinence, which was operationalized as both self-report negative for the primary drug of abuse, right, or any drug, and the urine negative for any substances over the course of the last 4 weeks of the trial. So that's weeks 9, 10, 11, and 12 of active treatment. Retention in treatment was also an outcome because we were aware that dropout from treatment is a big problem in community-based care, and it was hoped that the intervention would improve retention in treatment. So these were the two co-primary outcomes. Urines were tested with urine dipsticks. Sample characteristics, this was a fairly typical sample, we would say, for a community-based treatment program that's working probably largely with a Medicaid or similar type of population. There was a good ethnic mix. It was about 2/3 men and 1/3 women. Mean age in the 30s with quite a range. You know, a fairly low level of educational attainment. Only 15% of the sample had higher than a high school education. Very nice distribution across primary substances of abuse. So this was the intention of the trial, not to focus on any one specific substance problem, but rather to focus on patients coming to an outpatient program with any substance problem, mindful of the fact that this is an intervention that's really intended to be general. It is applicable to alcohol or cannabis or cocaine or whatever substances the person's using. One notable exclusion is that patients being treated on agonist treatment for opioids, that is buprenorphine or methadone, were not eligible. So these opioid patients were not on agonist treatment, and that turns into an interesting story later, as Aimee will show you. So primary outcome analysis, and basically here it is. What this graph shows is abstinence, abstinence as a binary outcome, the proportion of the sample that is abstinent, that's the vertical axis, somewhere between, well, 0 and 100, but it's 10 to 90 that shows. Along the horizontal axis is time. And patients were seen twice a week, so this represents 12 weeks divided into 24 half weeks. So the last
4 weeks of the trial are weeks 17 through 24. And what we see here is that there was an overall improvement on TES. TES is the dashed lines, and TAU is the solid line here and the dotted line here. Overall, if you just looked at the main effect of TES compared to TAU, it increased the odds of abstinence by a factor of about 1.5, a modest effect. However, we also had built into the primary outcome analysis plan that we would examine a key baseline covariate, and that is whether patients showed up at study entry abstinent or not abstinent. What we were mindful of is that we knew that a great many patients, when they enter outpatient substance use treatment, become abstinent very quickly. They stop using drugs and give a clean urine during the first week that they're in treatment. And that is a very powerful prognostic indicator. Patients that get abstinent right away are likely to do better in the long run. So we put that baseline covariate of abstinent or not abstinent into the logistic regression model, testing abstinence as an outcome, in addition to the treatment factor. And we tested the baseline by abstinence treatment by treatment interaction. And the baseline by treatment interaction is significant, and that's actually what we're looking at here in the graph. So the upper two lines are those individuals in the sample. This is about half of the sample, who were abstinent by the time they got randomized. They entered treatment. Within a week, they're already producing clean urine. And as you can see, as we would predict, this group has a very good prognosis. Over the course of the 12-week trial, they remain, 70% abstinent, more or less. Some of them will go back to using, but most of them don't. Very high abstinence rate. And there's sort of a trend here that TES increases the amount of abstinence compared to placebo. You see the dotted line compared to the solid line. But it's really very little difference. And this difference here is not significant. This represents an odd ratio of 1.17. In other words, patients who walk in the door already abstinent are going to do well over the course of the first 12 weeks. Adding the computer-delivered intervention didn't really significantly improve things. However, if you look at the patients who were not abstinent at study entry, these are the individuals with a worse prognosis. They're having a harder time quitting when they enter treatment. Here, you can see that the abstinence rate was twice on the TES group, the dashed line here, what it was in the TAU group. So the TAU group that enters study treatment not abstinent, by the end of treatment, they're only in the 15% abstinent range. Very few of them have achieved any appreciable abstinence. Whereas, among those who got TES, it's up a little over 40%. So it's really more than double the rate of abstinence among this bad prognosis group, and this is a highly significant effect in this group. So the bottom line take-home message, this phenomenon, some people get better right away when they enter treatment. They don't maybe need a whole lot more help in terms of the computer-delivered intervention. Patients who have a worse prognosis to begin with, they enter treatment, have a hard time getting abstinent right away. TES helps them get abstinent. A couple of other points about this graph. Yeah, the patients who got abstinent initially continue to do well, but some of them relapse. And if you look out at the 3 and 6 month follow-ups, the relapse rate continues. The curves are sort of slowly coming together. Remember that active treatment ended at week 24. For this group that was abstinent, not abstinent baseline, yeah, TES made them better, but they're still only 40% abstinent at the end of the study. There's a long ways to go to get these patients more abstinent. And again, what you see happens at the 3 and 6 month follow-ups is that the difference between these groups deteriorates. There's kind of a regression to the mean happening here across follow-up. And again, treatment ended at week 24. And so We don't know what would have happened if we had continued treatment for another 6 months, but we would hypothesize that what needs to happen is that this type of treatment should be delivered not just as a 12-week, one-time only thing, but should really be continued indefinitely. Otherwise, you're going to kind of lose the effect. So that is the primary outcome analysis, the main message from the study. We also looked at retention and treatment. That was the other primary. Yes, TES did modestly improve retention in treatment, and it was a significant effect. Not a big difference in terms of the numbers, about 10% difference, but it was significant, and that was good to know. The computer didn't drive people away. In fact, the computer increased the proportion of patients that remained engaged in community-based treatment. So, summary of the primary outcomes. TES increased abstinence compared to TEAU. The effect was strongest among patients still using substances at the time of randomization, that worst prognosis group. And retention in treatment was modestly improved also by TES. So that's the primary outcomes. I'll hand it over to Aimee, who's going to tell us a little bit about some of the interesting secondary outcomes that we have been able to continue to analyze this data set quite a bit and come up with some more interesting findings.
Great, thanks, Ned. So we're going to take a look at a few analyses looking at secondary outcomes, and then a number of analyses looking at some of the subgroup analyses or moderators of treatment. And we'll finish with looking at one analysis that looked at coping as a mediator of the treatment effect. So we'll start with secondary outcomes. And one of the things that we decided to look at and that Aaron McClure led the manuscript on was looking at smoking outcomes. And so smoking wasn't necessarily a target of the TES intervention. It was primarily focused on alcohol and illicit drugs. But we know that smoking is an interesting predictor of outcomes and has been shown to lead to worse outcomes overall in people that are seeking substance abuse treatment, and that there's a huge percentage of people with substance use disorders that are also smokers. And we found that in our sample as well. About 2/3 of the sample were smokers, about 391 of the 507. And among smokers, they were younger, more likely to be female, less educated, and more likely to be unemployed. All kind of descriptive characteristics that follow from the literature. Important to note that there were only about 4% of smokers who were using smoking cessation medications at baseline. So about 16 of the 391. And that didn't improve over the course of being in outpatient substance abuse treatment. So at the end of the 12 weeks of treatment, virtually no difference in the percentage of people that were receiving smoking cessation medications. So that's one kind of just more descriptive take home from this study to think about and to try to improve upon. So in terms of the outcomes, there was no reduction or quitting smoking over the treatment phase. So people really did not change their smoking patterns over the course of the 3-month treatment, and there wasn't any effect of being in TES on smoking outcomes. Smoking in general was associated with having poorer abstinence treatment outcomes. There was some kind of more nuanced subgroup findings with a 3-way interaction, which we won't really delve into, but really no kind of main findings related to smoking. The other thing that we wanted to take a look at in terms of a secondary outcome were data around the contingency management costs. And one of the barriers that's been cited to implementing contingency management within outpatient substance use disorder treatment is the cost of doing so, so the cost of the prizes or other types of incentives that are used. And given the primary outcome findings with the differences in effectiveness of TES based on abstinence status coming into the study, we were interested in looking at the differences between those who were positive for substances at baseline and those who were negative, and what contingency management costs look like between those two groups. And this analysis was led by our colleagues at Johns Hopkins, Maxine Stitzer and Colin Cunningham. And so we see that the distribution of draws, so these are earning draws based on abstinence and module completion, was different between those who were baseline positive or baseline negative. And you can see those who were negative at baseline for drugs and alcohol earned a median of 119 draws versus only 17 for those who were not abstinent at baseline. Similarly, those who were baseline negative or abstinent earned on average about twice as much in prize values as those who were baseline positive, so about $245 versus $125. And the median value of prizes earned was about 5.5 times greater for those who were abstinent at baseline. So kind of the take home from this analysis is that we might want to consider tailoring who would receive this technology-based intervention, which included contingency management, based on kind of prognosis at treatment entry, and in this case based on the ability to achieve some level of abstinence coming in. And this would help to potentially funnel resources required for contingency management to subgroups that might actually benefit most from them. So this was kind of an interesting analysis in thinking about future research around TES and potential implementation concerns. So we'll move now into some of the moderator analyses that we've looked at. We are currently working on several other secondary outcomes related to CTN-0044, which should be ready over the next several months, including looking at social functioning. So in terms of these moderation analyses, one of the first that we looked at was whether primary substance was a moderator of the treatment effect. So as Ned mentioned, we had a very nice kind of distribution of primary substance of abuse. Primary substance was based on or designated based on self-report. So we asked participants, what are you primarily seeking treatment for? What do you feel like is the biggest problem for you in terms of drugs and alcohol? And in this analysis, we found that so we looked at stimulants, we looked at those using alcohol as their primary substance, marijuana, and opioids. And you can see on this slide the numbers in each of those groups, with stimulants being the largest group, and that combined both methamphetamine, amphetamine, and cocaine. The only significant substance that moderated treatment was stimulants. And so you can see a 3.6 odds ratio favoring TES over TAU among participants whose primary substance were stimulants.
But I'd say what's really going on here is that the odds ratio is large for marijuana, alcohol, and stimulants, and similar, right?
Yes.
What's really going on here with this moderator is that it's opioids where it doesn't work. I think the fact that alcohol and marijuana miss significance is just really a function of sample size.
Right, and because stimulants had a larger sample size, 171 versus about 100 in alcohol and marijuana, that's what we surmised or hypothesized in the manuscript reporting these outcomes. Is had we had a few more alcohol and marijuana patients, we might have seen those odds ratios meeting the significance level.
It's really the confidence limit, it's not the point estimate.
And they're basically going in the same way as the stimulant group. So stimulants, alcohol, and marijuana seem to be acting in the same way, with TES outperforming treatment as usual. And just to recall that the opioid users in this group were those who were not on some type of opioid replacement medication. And so this, I think, highlights the need for medication-assisted treatment among this group, more so than kind of the effects of TES in general. One of the other moderation analyses that we looked at was gender, and this was basically biological sex, female versus male. And basically the take-home from this is that there was really no difference between men and women on a number of outcomes: abstinence, retention, social functioning, and craving. Gender did not moderate the effect of treatment, and there really was no main effect of gender on those outcomes either. What we did find that was interesting in this analysis is that women reported higher acceptability of TES early in treatment at week 4, but those differences between men and women were not detected at week 8 or week 12. And so the acceptability outcome was really a measure of 5 indicators of how satisfied people were with the internet-based intervention. What we did find among women, in addition, is that acceptability was associated with abstinence outcomes, but this was not the case for men. So women with higher acceptability of TES reported greater abstinence than those with lower acceptability. And this is kind of visually displayed in the 3 figures at the bottom of this slide. So you have the first figure shows low acceptability among men and women, median acceptability in the second figure, and high acceptability in the third. And so what you see is that among women with low acceptability of TES, they have much lower proportions of abstinence compared to men. And that those proportion abstinent increases as acceptability of TES increases. But you don't really see any change at all among the men. So women that like TES tended to do very well on it, but women that were less accepting of TES tended not to do as well. And among men, acceptability did not seem to be related to whether or not they achieved abstinence or not. So this is interesting, and when you think about gender differences in substance abuse treatment overall, this kind of follows the general pattern that we don't see kind of overall treatment differences, but there are definitely subgroups of women for which there are differences and for whom we need to take into consideration in terms of what types of treatment they might need. So several other moderator analyses that we'll just kind of briefly touch on, and overall we didn't find any subgroup differences. So Liz Evans has a paper under review now looking at 3 categories of age as a moderator of treatment effect. You can see those categories listed there: 18 to 25, 26 to 44, and 45 and above. Age did not moderate the treatment effect on abstinence or retention, but overall younger adults tended to drop out of treatment earlier, and this was irrespective of treatment arm. So that is a phenomenon we see kind of across the board, and it played out in this trial as well. In terms of people's internet access coming into treatment, this is also an analysis that is under review by our colleague at NYU. So we looked at whether people had internet access coming into the study, yes or no. About 74% did. This follows more or less with what we see in the general population, maybe a little bit less. And they were more likely to be younger and to have completed high school, those that reported internet access. And again, that follows with what we've seen from prior studies and internet accessibility in general. We did see a significant 3-way interaction between treatment, internet access, and baseline abstinence. So I won't go into the details on that, relatively nuanced, but overall there wasn't a major difference in internet access in terms of outcomes in the trial, abstinence and retention. Similarly, with criminal justice, Josh Lee, another colleague at NYU, has this analysis under review. Criminal justice status, so whether somebody was mandated or recommended to treatment, did not have any effect on abstinence or retention, and no moderation with the treatment. So overall, we didn't find huge differences based on some of these subgroups that we took a look at, some kind of more nuanced subgroup findings. But overall, TES seems to work well with a pretty average outpatient substance use disorder client. So finally, just we'll report on one mediation analysis that we took a look at, and this was looking at coping strategies. So we had a measure of coping strategies in this study. 23 different strategies. We asked how frequently people used them, and then we dichotomized that into whether or not a strategy was used, yes or no. And we utilized kind of a traditional mediation model to look at whether coping mediated the effect of treatment on abstinence at the end of treatment. And so following the model that's there on the slide, pathway A, the treatment on coping, we see that TES is associated with more coping strategies compared to treatment as usual. It wasn't a huge difference, it was significant. So those in TES reported about 19 coping strategies used compared to a little under 18 for treatment as usual. In terms of the pathway B, whether coping was associated with abstinence, that too was significant. So higher coping strategies scores were related to greater abstinence. And then we already know that there's a main effect of treatment on abstinence. However, when you include coping into the model with treatment, the treatment effect is no longer significant, indicating that there is at least partial mediation of coping strategies. So this was an important analysis, one in terms of looking at potential mechanisms of the intervention. Of course, CRA as a partially cognitive behavioral-oriented therapy, we would expect to see coping increase. And the coping strategies that CRA focuses on is not only kind of the typical relapse prevention coping strategies, but also things that would impact somebody's social environment, so things like the communication skills, etc. So we were pleased to see this, and we also have several other potential mediation analyses planned. So that is kind of a summary of where we are to date in terms of some of the secondary analyses from this trial. Like I said, there are several more analyses that we're interested in doing, and we're always interested in collaborators as well if you have any interest. So I'm going to turn it back over to Ned, who's just going to kind of briefly sum up where we are in terms of.
Yeah, just to summarize and where we go from here, I think it's a large and very carefully conducted trial. It shows that TES is effective in improving treatment outcomes and abstinence and also retention and treatment. The additional costs of TES and the vouchers was modest. Opioid-dependent patients did poorly. They need to be on a medication. The study didn't disentangle the effects of contingency management from the computer-delivered counseling, the CRA. But again, other studies had shown that the intervention was a function of the sum of its parts, and that both the CM and the CRA contributed. So really, TES is effective, and it should be implemented. That's sort of a next step implication, which of course, as we know, implementation is always a little easier
oh, whoops, how do I do this? Easier said than done. There are, of course, other NIDA-supported computer-delivered interventions, including CBT for CBT, developed by Kathy Carroll et al., which has also been translated into Spanish. And this one is really focused on purely on cognitive behavioral relapse prevention. So it's similar in some ways and different in others. It's a more concentrated dose of relapse, basic relapse prevention skills. And of course, there are potential barriers to implementation: funding, reimbursement. Can treatment programs bill for having the patients work on a computer rather than talk to a person? And then there's the issue of training clinicians on technology-based interventions. I think it's our impression that clinicians, once they got a little experience with TES, and by the way, we ask clinicians in their counseling with patients to discuss the TES with the patient, if the patient was in the TES arm. And so there was a little bit of interaction between patients and clinicians around the TES. Clinicians, I think, by and large, liked it once they figured out what it was doing. They got the feeling that it could be a useful clinician extender, which is how we really intended to test it in the trial. So future directions for research outside specialty addiction services, TES and medication-assisted treatment, mobile handheld devices. There's several efforts underway now to take TES and put it onto a mobile platform. Innovative research design. So one of the things to point out is that TES was developed in probably about 2003. Or 2004. The first randomized trial was published in 2008. So if you think of this thing being built and developed in 2003, that's now 13-year-old technology. It's ancient technology. It's clunky. It's on a computer. And look at how many years it took to develop it and do clinical trials, including a definitive efficacy trial. And we know that technology is evolving massively every year. So I think there's a challenge to try to come up with innovative, fast research designs that can really test efficacy and effectiveness quickly and keep pace with the pace of technological advances in terms of smartphones and smart devices and what they can do. And then using interdisciplinary teams to understand how technology is employed. Trying to understand really how a technology-based intervention like this fits into a team of clinicians that's working with the patient. I'm convinced that the greatest value of this is not as a standalone replacement for a clinician, but rather as an extension and amplification of the clinician's efforts in trying to help the patients. And there's now there's a blending product which is available, which was based partly on this trial, and there's the acknowledgments to many CTN grants. Martina Pavlikova and Mei Chen Hu, who are our statisticians here at Columbia on the secondary analyses. The team at EMIS, including Abby Matthews, who was the primary statistician on the primary outcome analysis. Tremendous amount of work done by all 10 sites. This was a ton of work, and the sites all performed really well. And of course, the lead team, here at the node. And I think with that, we have a little bit of time for some questions or comments, if anybody has them. Particularly thoughts about, where to go next with this, and particularly how to implement it and how to test implementation.
I see a few questions in the chat box. Gloria, thank you. Asked if these results seem to indicate that there isn't necessarily a huge digital divide in clients and substance abuse treatment. And I would say overall that is true. I think we see slightly lower numbers in terms of internet access than we do in the general population by about 10%. But I think as we're seeing overall in terms of the digital divide in the general population, that seems to be narrowing, and that certainly anecdotally in talking to our colleagues in community-based treatment programs, it's really not uncommon for kind of most clients to have access to phones, smartphones, even though that access might be a little spottier sometimes. In terms of not always being able to pay monthly bills, et cetera, and phones getting turned off. But I think in general it's narrowing, and we saw about 3/4 of our sample with internet access. All right, another question, did you look if there were any race or ethnicity differences in internet access? We did look at that in that analysis. I don't believe there were any significant differences by race ethnicity. We did see differences based on age and educational status.
The counselor seems to be a missing element here. Question from Steve Gilbert. Any thoughts about training counselors to integrate TES with TAU? Yeah, excellent question, absolutely. The framers of this treatment, I think, imagined it as a standalone, that the clinician would be doing separate things. I felt strongly going into it that we really wanted to think of this as a clinician extender. There was no systematic way of integrating the clinician's efforts with the computer-delivered therapy when the trial was initiated. So what we did was we asked clinicians to talk to their patients about the modules and just to talk about it. And we had a little form where we asked clinicians to document whether they had talked about it or not. And we have a little bit of data like that we're looking at now. Ideally what we envisioned was that the clinicians would have really a detailed conversation with the patient. What did you learn from the modules you did this week? How can you apply that in your life? Could we come up with some homework assignments that you might carry out based on what you learned from the module? This is the kind of conversation that a computer is not going to be able to have with a patient anytime soon. This is the kind of thing that a clinician is ideally suited to do. And I think that's really a future direction, is to look more deliberately at how the clinicians will work with the patients around this. And I think one way that can work is for the clinicians to actually go through all the modules so the clinicians know what's in the modules. And I think anecdotally, clinicians that did that over the course of the trial were really very positively impressed with it. They said, gee, this is really good content, it's good education, and we can use this to reinforce the work that we're doing with the patients.
Yeah, I would just add to that as Ned mentioned, we are taking a look at some of that data that was collected directly from the clinicians who interacted with TES participants as part of their individual counseling session. And we looked at clinicians who were had greater involvement in terms of actually talking about specific modules or recommending modules. And some preliminary analyses have shown that clinicians that were more involved, their TES clients had better retention and module completion. So those are some analyses that will be coming out shortly, but I think it's a signal in terms of how Ned mentioned earlier, this kind of amplification of the TES effect with interaction with the treatment providers. So I think that's going to be an interesting point, and I think it gives us some suggestions for how this might be more systematically implemented.
Okay, Brian Heckman, what steps would need to be taken to have the technology itself covered by insurance?
I No, I think that's a good question, and I think partly policy is a kind of a major next step in moving technology-based interventions into a more prominent role in terms of behavioral health care. And so policies that would cover devices, for example, I think we know of some colleagues of ours who are interested in looking at getting FDA approval for some types of technologies, and I think those kind of pushes will help to really move this idea around using technology as a viable treatment that's covered by insurance, kind of more into the forefront and more into reality. But it's an important point that we need to, jump into that conversation with at a policy level.
Ned and Aimee, we have time for one more question.
So Louise Haynes has a question that slide 20 showed contingency management most effective with clients who were abstinent at baseline. It's actually the other way around. This is the slide. Contingency management is most effective. Contingency management, or TES, was most effective among patients who were not abstinent at baseline. And again, in the intervention, we didn't separate contingency management from the computerized CRA. They were both tested as a package. And so what this data seems to show is that, in fact, TES was effective in helping patients who were not abstinent at the outset to, in fact, initiate abstinence, more so than treatment as usual. So it was helpful in helping people initiate abstinence. If anything, it wasn't so helpful, in helping people prevent relapse. Maybe a small effect here, but very, very small. This could be a kind of floor effect or ceiling effect. So I hope that clarifies it. That what the trial shows is that the largest impact of TES was, in fact, to help patients initiate abstinence.
Great. Well, that will be the closing word there, Ned. Thank you both, Aimee and Ned, for coming and sharing this information with us.
Well, thank you for organizing it. I hope everyone enjoyed it.
Thank you. If you have any more questions, you can send that to ctntraining@ms.com, and I can send those over to Ned and Aimee and get you more answers. We will post the recording of this presentation on the CTN Dissemination Library's website as usual, using the link provided here. And we invite everyone to come back actually in July, where we will discuss assessing neurocognitive brain imaging and substance abuse measures in emerging adults. We have a guest speaker, Stacy Gruber from McLean Hospital and Harvard University professor. So we welcome everyone back in July on the 13th, and we'll send an invite out for you to attend. So thanks everyone for coming, and I look forward to seeing you all again in July.